Thank you. Good morning, everyone. So as I go through my lecture today, I'm going to try and dispel this myth that has been present for several years about no need to rush, it's only a stroke, and I hopefully throughout this talk I'll be able to change your mindset and that we treat stroke as an emergency. So to start off, let's talk about the societal impact of acute ischemic stroke. It is the leading cause of adult disability in the United States. It's the 4th leading cause of death and the 2nd worldwide. We were the 3rd leading cause for several years, and recently, due to probably medication and more public awareness, we dropped down to the 4th leading cause of death. There are about 800,000 new strokes each year, 5 million plus stroke survivors, and we spend over $70 billion per year in the United States taking care of these patients. So essentially, 1 in 6 Americans might have a stroke, and of those who actually have a stroke, 90% will have some form of a residual deficit and certainly will be some kind of a burden to us in the future as we have to take care of these stroke survivors. So this is a slide that's a favorite of Dr. Saver, who's the head of our stroke center. He likes a lot of numbers. So he went through and calculated that in a typical acute ischemic stroke, every minute the brain will lose 1.9 million neurons, 14 billion synapses, and 7.5 miles of myelinated fibers. So time is brain essentially, and we have to move very quickly if we recognize that a patient is having a stroke. So some of the strategies that we use to identify patients have changed over the years. Initially, all we had was a non-contrast CT. Much of our early data was based off of CT studies. But as we've moved forward and as new imaging techniques have come into play, we've moved away a bit from just the time limits that we give ourselves for taking care of stroke patients. And we move more towards using imaging and other features, including the clinical presentation and time, to help manage these patients. So when you suspect an acute ischemic stroke, the thing that you want to sort of identify is whether or not there is salvageable tissue that's available for us to go after and try to recover. And we use our imaging to help us in that way. So hyperacute patients are quickly identified and imaged, and we go through using multimodal CT, multimodal MRI to identify these patients. Again, we're kind of moving away from the ticking clock and just mostly only time, and we're going towards the tissue clock where we are still using some of a clock and time, but we are also using imaging to help guide our recanalization therapies. So here I'd like to just point out what we do. We typically will do a multimodal CT in patients who are not MRI eligible here at UCLA. However, all of our patients 24/7, if they are able to get MRI, will get MRI. So if there's a patient in the scanner, as long as they're non-emergent, that patient will get pulled out for an acute stroke code patient, and our patients go in. And the neurodiagnostic and radiology fellows and attendings are usually here to help us do any kind of reconstruction that we need emergently. We use the DWI, or the just non-con CT, to identify what tissue is has already been damaged or is ischemic. We use the perfusion CT to assess hemodynamic compromise and essentially what is our penumbra, what is our salvageable tissue, and then the CTA or MRA to identify where the occlusion or stenotic lesion is. One of the key studies that helped us in kind of moving towards this tissue instead of time was the DIFFUSE trial. This was the diffusion-weighted imaging evaluation for understanding stroke evolution. It was essentially a landmark study using diffusion MR. Patients were selected in the 3 to 6 hour window after they first were discovered to have symptoms. And what it essentially showed was that there were specific mismatch patterns that identify patients who might benefit from treatment early on. There were patients who likely would not benefit because they had an essentially matched lesion and no penumbral tissue to salvage. And then there was also a very useful malignant pattern where if they had a significant amount of brain tissue that was already damaged, those patients did not appear to benefit. So to illustrate, this was the mismatch pattern that they identified, again, looking at patients, and they correlated also with the NIH stroke scale, which is the scale, a grading scale that we use for the clinical findings of a patient who has been identified to have a stroke. And so as you go through here, you see the volume on the diffusion-weighted scan, the perfusion scan with the area of mismatch, and then the occlusion here. And then subsequently, after treatment for this mismatch pattern, the patient's NIH stroke scale dropped from 16 to 5 at 4.32 hours from last known well time. In addition, you see the perfusion abnormalities have resolved. Also, the imaging with the occlusion has improved. This demonstrates the malignant mismatch pattern, again, with a significant burden of tissue that's potentially at risk. And so this patient was opened, did not do well. And so as we identify patients who are possible recanalization candidates, we look at this pattern, and we usually exclude patients with this particular pattern. So some of the key points that this trial helped us with, we again were able to identify patients who would likely benefit from early reperfusion, and again, patients who would likely not benefit or do poorly if we were to intervene and may actually cause harm in. So as we move forward here, we'll start talking about recanalization therapies, the different types that are available to us today. Starting with IV thrombolytics, so we'll talk a bit about IA thrombolytics, endovascular devices, and then go into some of the emerging options that we have available. So our pivotal stroke trial is the NINDS TPA stroke trials 1 and 2. Essentially what these trials demonstrated and led to the approval of IV TPA for treatment of stroke was essentially that patients benefited and had great recovery after receiving TPA versus placebo, and their risk of hemorrhage or significant enough to cause death was within a value that was deemed appropriate or okay, considering the major benefit that a patient could potentially receive if they were treated with IV TPA. So IV TPA was approved for use in under or patients up to 3 hours. And when you look at the changes in outcome due to treatment, patients tended to improve. So again, looking at numbers that you can maybe memorize or be familiar with, for every 100 patients treated with IV TPA, 32 patients would benefit and 3 patients might be harmed. One of the problems that we run into is that we have a lot of clinical data, and we have to ask patients and their family members to make quick decisions when they come in through the emergency room or if they're having a stroke in the hospital. And so we have developed techniques in which they can easily understand what's going on. So this was one of the ones that we developed here, just basically drawing out the number of patients that might benefit and versus the patients that might be harmed in a quick, easy way for them to really recognize and understand what our numbers mean. So for ischemic stroke treatment, 2011, we have IV TPA. It is the only FDA-approved therapy for acute ischemic stroke, and it's only approved for a 3-hour time window. As we move forward, some people asked, well, so the trials were done with this 3-hour time window, but what if we extended this time window? Would patients benefit at a later time, or would they be harmed? So there were a lot of trials that kind of enrolled patients later or extended that time window out to 6 hours, some of them 9 hours. And so there was a pooled analysis that basically showed that perhaps there was an improvement if you treated patients outside that 3-hour window. However, it was much, much less than the significant improvement that they might have if you treated them early on. So again, you know, the whole time is brain, even though we like to throw in tissue there, we really want to try and get the therapy initiated very early on, and not wait for that extended window and, you know, wait for labs or wait for, you know, figuring out exactly what's going on, wait for imaging. If you can't get the imaging fast enough, you go for your non-contrast CT, which was what, again, all of the early clinical trial data was based off of. So ECAS-3 was, there was an ECAS 1 and 2 prior, but ECAS 3 was another pivotal trial that was recently published in 2008. Basically, this involved about 800 patients, and again, the entry criteria was very similar to the trials that approved the 3-hour time window for IV TPA, but it excluded patients who were older than 80, patients who had a very significantly high NIH stroke scale score greater than 25, whether or not they already had a third of the territory affected on imaging, and if they were on warfarin, regardless of what the INR is, which is different from the NIH NINDS trials, where if your INR was less than 1.7, you could still be enrolled. But this trial completely excluded anybody as long as you were told that they were on anticoagulation. Also, based off of earlier trials, anyone with a combination of prior stroke and diabetes was excluded from this trial. And essentially, the rate of symptomatic hemorrhage was pretty comparable, mortality comparable, and the patients indeed had a much better outcome if you extended the window. So the window was extended to 4.5 hours. Again, in this specific group of patients who did not meet any of the exclusion criteria. And what they found at the number needed to treat for benefit, patients who improved was 7.1. Again, quick numbers to memorize. For every 100 patients treated with TPA in this window, 16 would benefit and 3 were harmed. And that was considered good enough for the American Heart Association and the American Stroke Association to review their guidelines and to make recommendations that you should consider this, but it was not considered by the FDA for changing their guidelines. So it is AHA and ASA endorsed, but not FDA approved. And so if you have an examination and this is ever on the test, the extended window would not count. Only FDA approved therapies count. Again, remembering that there are specific criteria for this, for enrollment in this extended window. Usually here, at most hospitals, if we're going to treat in this extended window because it's not FDA approved, we do consent the patients or their family members, and we make sure we clearly outline the risks and benefits for the patients. Just to kind of talk about the acute IV TPA trials and keep it all in the same category here, clot bust or using TCDs in the treatment of acute ischemic stroke, patients has been very, very much studied, and there are ongoing trials right now. The pivotal trial was clot bust, and essentially was a non-randomized, non-controlled, prospective phase 1 trial. But essentially, they were treated. Patients were treated with full dose IV TPA, which is 0.9 milligrams per kilogram, maximal dose of 90, and they were simultaneously had TCDs on as they were getting the bolus and the infusion. There was complete recanalization in about 36% of these patients. In these patients, there was about 20% dramatic recovery in that the patients got spontaneously better and had no measurable deficits at 2 hours, and 24% of them had dramatic recovery at 24 hours. Their rate of hemorrhage was pretty comparable to earlier trials. It was 9%, and so oftentimes we consider doing this in patients. We are not part of the trial here, and we do have portable TCD machines, but it's very difficult to get a tech in to do the TCD simultaneously with TPA. So it's not routinely done here. So does it actually work? Are we actually using this in routine clinical practice? Well, it's kind of sad to talk about these numbers, but only about 3 to 4% of stroke patients actually get TPA. And those numbers haven't changed at all in the past several years, despite us going out and trying to educate patients. So the biggest barrier is usually patients getting to the ER, recognizing the signs of stroke, getting to the emergency room, getting to a facility where they can consider them for TPA. The other problems that you run into are patients might get there on time, but they have a contraindication, or part of what I'm interested in right now is there are physicians in the emergency rooms in these small ERs who are not familiar with using TPA, they're not comfortable giving it, they might not have the right information about the benefits and risks of giving TPA, and so they don't feel comfortable and they don't use it, and they don't have neurologists or stroke specialists available to help them out. So one of the ways we're trying to help increase the number of patients getting TPA is through the use of telemedicine. Basically having access 24/7 to a stroke specialist if you don't have a neurologist or someone available who's willing to give TPA to a patient. So essentially, again, 3 to 4% of patients only getting TPA. The efficacy is pretty similar to the trial, so it kind of correlates to routine clinical practice. The rate of hemorrhage is about the same as well, 6%, and the risk of hemorrhage increased as it did in the trials with protocol violations. So definitely, as you increase the window, the time window, and you violate the protocols, patients can bleed if you don't manage their blood pressures appropriately. Sometimes patients get the wrong dose because the physicians aren't aware of what to give, or the pharmacy mixed the wrong dose, and also elevated blood sugar, so hyperglycemia can definitely cause an increased risk of intracerebral hemorrhage in these patients. So some of the advantages of IV fibrinolysis, essentially it's proven benefit within 3 hours of symptom onset, rapidly initiating the thrombolysis, and it's widely available. You give it in an ER through an IV access. The disadvantages are that you basically are giving a pretty low concentration of lytic agent. It's not really getting to the clot site quickly. The recanalization rates are pretty poor. It's only about 30 to 40%. And you also expose the patient systemically to a thrombolytic agent. So let's move forward now and talk a little bit about IA recanalization therapies. The advantages here are you give a higher concentration of the lytic at the clot site. You can do gentle mechanical disruption of the clot, and the early recanalization rates are a lot higher at about 60 to 80%. You're also getting a lot of good knowledge about where the exact location of the occlusion is, what your recanalization numbers are. So there are different scoring scales for determining the degree of recanalization. However, the disadvantages that you run into are that it delays therapy, because obviously you have to have the patient at an angio suite. This may only be at a specialized center, and so you have to transfer the patient, get them on the table. There's a lot of things involved in actually getting the angio started before you can give the therapy. And also then you run into procedural risks such as vessel rupture, dissection, and those types of things. So IA, just intra-arterial fibrinolysis. There have been single randomized controlled trials suggesting beneficial effects, but no single randomized controlled trial has demonstrated that IA fibrinolysis gives you increases in outcomes when compared to control. And this is probably related, the studies were pretty small, they were not statistically well powered, and so this is probably the reason why this has never led to the FDA approving intra-arterial thrombolysis therapy. The recanalization rates, when you look at the PROACT trials, which were the pivotal trials for IA therapy, were pretty sizable at 66%. The symptomatic hemorrhage rate were pretty comparable to the NINS trials. So, and then there have been multiple meta-analyses suggesting again that IA fibrinolysis substantially increases recanalization rates, and the hemorrhage rate is no higher. However, again, this is not FDA approved. So for every 100 patients treated with IA TPA, 24 will benefit and 4 might be harmed. And so again, remember, not FDA approved. It is effective up to 6 hours, so it kind of brings your window to 6 hours, and again, it very similar to cardiac lysis. So we'll move towards all of our mechanical therapies now. The pivotal trials here, the Mercy mechanical embolus removal in cerebral ischemia. That was, the device was developed here at UCLA, and the trials were done here. And so essentially prospective, randomized and non-randomized multicenter trials. Patients were either ineligible or received TPA and failed. And the recanalization rates here were, in the initial trial, 48%, but in the multi-Mercy trial was a bit higher, but still in the 40 to 60% range. And certainly symptomatic intracerebral hemorrhage rates were pretty comparable. The trial design in many of the devices were pretty similar. NIH stroke scale had to be greater than 8. They extended the time window even further to 8 hours. And you definitely had to see angiographic occlusion of a large intracranial vessel. Most of these were anterior circulation, and the patient had to be ineligible or refractory to TPA therapy. So this is Multi-Mercy comparing Multi-Mercy to Penumbra, which was another device that I'll show you later on. And essentially fairly comparable, matched number of patients with regards to the NIH stroke scale score. Device recanalization, however, was a bit higher. Penumbra is in white. With Penumbra, at about 82% device recanalization versus 68%, and the rate of symptomatic hemorrhage, again, was pretty similar. Multi-Mercy also looked at patients, specifically, we just looked at the failed IV-TPA patients, and there was benefit in these patients who failed IV-TPA to going on and doing adjunctive therapy. This is just a picture here of the Penumbra devices. Again, their pivotal trial showed recanalization rates that were the highest that we've seen for any devices for ischemic stroke. And again, 82%, but their standards and the way they got these numbers were a bit different from other trials, and so it's likely that it's not as high as that. Again, their ICH rate was about 11.2%, and they had good outcomes at 30 days and 90 days. So mechanical embolectomy, unproven, FDA approved, so it's approved for up to 8 hours of use, although again, we again take everything into consideration, and you will see that we do cases here sometimes looking at the tissue, we might extend that window out, but the FDA approval is for 8 hours. And again, very useful if the patient has a TPA contraindication. Both devices, Mercy and Penumbra, were FDA approved for use. This approval is for device approval for removal of a foreign body. It is not an outcomes-based trial. So going through to just kind of recap what your options are. Your FDA-cleared interventions, IV-TPA, your only drug therapy for 3 hours. Mercy and Penumbra, 8 hours. And you can consider IA lithic, but that is not FDA approved, and that's up to 6 hours. The one controversy that exists is that there has been no direct head-to-head comparison of these devices versus best medical therapy. And so that's ongoing. We're actually involved in both trials here, the IMS-3 trial and the MR Rescue trial, where we're essentially going to randomize patients to either getting full dose or 2/3 dose of IV-TPA plus mechanical, or IV-TPA versus mechanical. And so these are ongoing right now, and hopefully we'll have an answer in the near future. Just to kind of talk about some of the future devices that are coming up. Swift is a device, and so they're essentially looking at this device versus the Mercy. And so we are also involved in this trial here. I actually just went to the trial startup yesterday for this trial that we will probably get started on early next week or so. It's already approved here at UCLA and through our IRB. It's another device. There's lots of these stent-assisted devices that are on the market now, and the window is still the same, 8 hours. Most of the inclusion-exclusion criteria are all the same, just basically looking to see whether or not these devices are more beneficial over the older devices that we have. And then there's also acute stenting that's also considered, and SARIS was the stent-assisted recanalization for ischemic stroke. The FDA approved a pilot study with the Wingspan self-expandable stent, and so we were really looking forward to this and considering stenting for intracranial disease in patients. However, the large NIH trial that was just started up within the past few years was halted because of too many deaths in the device arm. And so we haven't been able to definitively answer whether or not acute stenting or stenting of these intracranial vessels is beneficial to patients. And then there's Plasmin. Dr. Marder is one of the hematologists here. who's been working on looking at other alternatives to treating stroke patients. And so they're doing a dose escalation study that's ongoing now in Europe, looking at plasmin for treatment of acute ischemic stroke. And so what I thought I'd end with here is a case presentation, just running through one of our recent cases here, how we sort of identify patients and the process. So this was an 83-year-old right-handed woman, sudden onset of speech difficulty and right hemibody weakness. Her last known well time was at 7:05 p.m. They actually called 911 at 7 minutes after her last known well time. While she was in the field, this is one of the ongoing trials that is being headed by Dr. Saver here. It's NIH sponsored. The patient received, was enrolled in FastMag, so she either received normal saline or IV magnesium at high doses, which has been shown to perhaps reduce, to be neuroprotective. And so she started that drug at 33 minutes from her last known well time. She got to the outside hospital within 49 minutes and was treated with IV TPA at 1 hour and 54 minutes. They only had CT there, so she had a non-contrast CT, which did not show any significant early infarct signs, but the arrow there clearly demonstrates a hyperdense MCA sign, which is something very important to look for in your scans. It's often missed, but consistent with slow flow or sluggish flow within the vessel. She was flown here and underwent emergent imaging here. So once a patient gets transferred here, we do not just go by the imaging that was done at the outside hospital. Even though time is brain, we need to see exactly what's going on with the tissue. And oftentimes, all we have is a non-contrast CT. So we get multimodal imaging here to further identify these patients. Again, going back to the FUSE trial, trying to identify patients who may or may not benefit from intervention. And you can see here the perfusion scan shows her diffusion-weighted imaging with the ischemia here. And then the perfusion scan showing a significant degree of penumbral tissue that's at risk. And then the occlusion. This is Dr. Jahan as it gets started on the patient here. This is the first shot of the angio. This is the Mercy clot retrieval. It's that corkscrew device that gets deployed. And then this was the subsequent result of that patient, the small clot with the device right there. And so going through the time again, she got to UCLA at 3 hours and 17 minutes. Multimodal MR was done by 3 hours and 39 minutes. Her first Mercy pass was at 4 hours and 22 minutes, and she had perfect recanalization at 4 hours and 51 minutes. And so here are her pre-recanalization scans, and then her day 5 scans, showing that there's this area that was ischemic here has essentially infarcted. However, the rest of the territory has essentially normalized. And so I'll leave you with time is brain. I'd be happy to take any questions. Thank you.